We do this because we believe in this technology. It is just intellectually stimulating, and the prospects for the future, to know that we might be impacting care for millions of patients in the future, I mean, that's really why we're in this business.
Recently, the physics school at Les Ouches played host to a group of experts and young scientists who met to consider one of the most exciting fields in all of medicine, the application and future of high-intensity ultrasound used for therapy.
So we are organizing a winter school on therapeutic ultrasound here at Les Ouches, mainly for students. We want them to learn as much as we can during 1 week about therapeutic ultrasound in general, focused ultrasound. And we do it here because first it's a lovely place, but it's also a remote place, so everyone is just staying together and they're having scientific discussions during lectures, but also during lunches, dinner. We all stay together for 1 week. A completely different atmosphere as compared to conventional conferences. So the students get to know each other, and they also get to know better the lecturers.
The idea of this winter school is to bring everyone who's in the early stages of learning about research in therapy ultrasound or clinical work in therapy ultrasound together, so that they can all learn the basics, but also get to know the people who are at the top of the field. The faculty are chosen from some of the best people in the area, so youngsters can feel at ease with their superiors. And it's a great way of meeting people and getting to know people. You meet over breakfast, you meet over lunch, you meet over dinner, you go to lectures, you meet in the bar at night and you ask, provocative questions. And it's just a way of developing a friendly field. Therapy ultrasound is an extraordinarily friendly field because we all have a common aim of trying to treat patients.
I'll give you an introduction, then we'll look at some basic physics to do with the acoustics, reflection, pass through the skin, through different layers of tissue, fat, muscle, for example, on the way to the organ.
I'm just starting my PhD. I come from a more sciencey background, not so clinical as everybody else, and I really wanted to get a grasp of what's relevant right now and what's not.
Since I'm doing my PhD in therapeutic ultrasound, so this was the best opportunity I could have.
Just first, sound is a longitudinal wave. You have a transducer, it vibrates backwards and forwards, it couples into a media, and you generate sound waves that travel down through that.
I think it's very good for people who first need to learn the basics, but also for us who already know ultrasound or MRI. It's a very good place to connect to other people, to see what other research groups are doing.
You get like the whole picture in just 5 days. Normally you would have to read about like half a year or something.
Nice things come when I spin it and then do the same again, and it doesn't drop, but precess. This is what we call precession.
So hopefully I'll get some rich knowledge from here and can apply back home.
This is an example of a patient who was treated with ultrasound-guided HIFU. So this patient had pain. Oftentimes, if this tumor involves the celiac artery, they almost all have pain. And this is a patient, this is 6 months post-HIFU. You can see an area of non-perfused area demonstrating ablation, and the patient did have improvement in pain.
I've been talking to a lot of students from different universities about our project, and I already got some great feedback and new ideas to do in my research.
He took 36 patients, stage 3 and stage 4, and treated with HIFU ablation plus chemotherapy, and gave this very impressive survival curve that shows 33% survival at 5 years. This is almost unheard of.
And also, you have like all these brilliant minds, you just could talk to them, and it's like really friendly, and yeah, it's kind of cool.
And the T-fastener keeps it in place.
Exactly. And when it's gone, it's gone.
I enjoy coming to the winter school to interact with the students and the faculty here. I've been coming here for, I think the first time I came to a school like this was about 8 years ago, and so developed some good collaborations, even with some of the students who are now faculty members at other institutions. Therapeutic ultrasound is a very challenging field because it requires multiple different expertise to come together to collaborate to make this thing work. From the most basic standpoint, you need high-quality engineer and scientists to get together with interested clinicians, and that's probably one of the hardest collaborations to get going.
As a clinician, the view of HIFU and ultrasound is they think it's complicated, is difficult to do, is too long, and since so many years, people are not really believing they can do it. Our job today is to make it accessible and easy to use by everyone. That's our job.
I would say, the importance of this field in general is, from a scientific standpoint, of course, it's very interesting. But I think, as a biomedical engineer, I can say that one of the major motivations of our field is the translational aspect. So actually seeing these technologies move forward and manifest in a really meaningful way in the clinics, and patients with essential tremor are seeing real effects from these treatments, and, it's essentially changing lives. The great thing about this is that it's such a novel area and sort of an up-and-coming field that for the future there's a lot of excitement in terms of continuing to propel emerging technologies and better understanding them.
Mainly the thing that I really enjoy, you spend a lot of time on your own often in research, even if you're in a big group. You spend a lot of time looking at papers and being online and in front of a computer or in the lab. And these kind of things gives you an opportunity to actually not be on your own and talk about something that you are really excited about and find really special, and other people do too. And that's really great because you suddenly go, okay, I'm confirming I am doing something that feels worthwhile. And I guess that's probably just at the basis of it all. It feels like, yeah, these are my people, they know what I'm doing, and that's quite nice.
Enjoying it. The Engineering Physical Sciences Research Council has funded this network for ultrasound therapy, which we call Thunder. I'm really excited about this because it means that we can try and bring together the whole of the therapy ultrasound community in the UK. We can work together, we can initiate joint projects, and we can start to tell the rest of the UK clinical community about what therapy ultrasound can do. It's an enormous opportunity.
When you're a kid, you often get your first magnifying glass. And this is a wonderful toy, and you use it to look at things, and then you get the idea, or somebody tells you, that you can focus the rays of the sun down to a spot. You can start a fire on a leaf or on a piece of paper. And this is an incredible thing. Then I thought, well, ultrasound is a wave, and sunlight is a wave, light is a wave, and ultrasound is a wave. But the light doesn't penetrate the body, but ultrasound does. And I thought, now you could cause a fire, you could cause cauterization in the middle of your body. Anywhere that ultrasound could penetrate. All you have to do is focus it. That just seemed like a remarkable advance.
It's like a superhero skill. It's like a sci-fi thing. You can't see it, you can't feel it, but it can go into the body and burn things. It can do surgery inside the body without making a cut. Just, people understand like diagnostics, so they know, if anyone's been pregnant or had someone pregnant in the family, they know about ultrasound. And so they know that it doesn't hurt because they've had it, they've seen it on TV. And then for that to actually go in the body and treat, that's amazing.
What is fantastic is that you just see the organ through MR or ultrasound, so you have those very fine imaging, and you select the target, you tell the ultrasound where to aim at, and you can focus ultrasound exactly at that same location and induce a broad range of bioeffects at that location.
Focused ultrasound beams break up tissue by causing cavitation, bubbles created by the heating effect.
This cavitation process is fascinating to watch. That's really one of the things that got me excited about the field, was seeing Larry Crumb's movies of cellular debris in a fountain where the ultrasound sound waves were focused. And I thought that creation of micro parts of cells could be a great stimulus to the immune system.
There are two aspects to this. So one, there's just understanding how sound waves pass through the body. It's an intellectual exercise that is a very compelling and interesting problem. But then what's very nice about this is that we can actually, by making advances in understanding that, we can actually help people in their lives. Using shockwaves to break up kidney stones is probably the first major application of using ultrasound as a therapeutic mechanism. It's been used now for 3 decades to be able to break up kidney stones. It revolutionized the treatment of kidney stones. Before that, you had to have open surgery. Once this technology came in, within about 5 years, at least in the US and in the UK, 90% of kidney stones were being treated with shockwaves. What we are envisioning as we take ultrasound on to look at other applications, so for example cancer, treating in oncology, we're hoping to be able to make the same sort of difference.
It's important that it's non-invasive because, for instance, if you're treating the brain, if you're going to do deep brain stimulation, which is an alternative for the essential tremor treatment, you have to insert something into the brain, and the track on which you insert it, you do damage. So if you have something where you don't do any damage except at the central region where you want it, then that must be an advantage, surely. Also, if you don't have to breach the skin, so if you have a non-invasive technique which allows you to get into the liver or the pancreas without introducing any probes into the body, then you don't run the risk of infection. It's just extraordinary how much you can do with it. It's the most versatile form of energy. You can use it at low powers to enhance drug delivery. If you use it at high powers, then you can kill cells by heating, by cooking them. I usually say if you can reach a region of the body with ultrasound imaging, then there's no reason why you can't treat it with therapy.
Ultrasound has the ability, probably within actually the next decade, to start making serious inroads in at least 2 areas of cancer treatment. So one is the direct ablation, so using ultrasound to heat up and destroy tissue. So there'll be a direct competition with surgery or with radiotherapy. The other thing that ultrasound has the ability to do is to help with chemotherapy. So one of the major issues with chemotherapy is you give drugs that are essentially poisons. They poison the cancer, but they also poison the other cells within your body. And what we can do is we can encapsulate those chemo drugs in little agents that are sensitive to ultrasound. So you inject them in the body, they're encapsulated in this nice, safe little membrane. And then if we fire ultrasound in, we can actually tune the ultrasound to pop that membrane and deliver the drugs to just the right place. So for example, if there's a tumor in the liver, we focus the ultrasound into the liver. The drugs are only released in the liver. You have a high concentration of the chemotherapy in the liver. As those chemotherapy drugs pass out of the liver, they will get diluted down by blood elsewhere, and so the rest of the body will not see such high concentrations, and so the side effects should be reduced.
But there's another quite speculative way in which ultrasound could be used to attack cancers, to help the body's own therapeutic agents, the lymphocytes, to get into cancer cells to destroy them from inside.
So some tumors, pancreas is a good example, are so dense and so apparently difficult for lymphocytes to get into the spaces where they need to work. A technique like HIFU might make that possible. It's a similar problem that we have in immunotherapy to get drugs inside tumors too, because the blood vessels often are closed. There's high pressure in some tumors that collapse blood vessels that prevent blood from perfusing into the tumors. And actually that's the system that the immune cells also traverse into the tumors. So this idea of pressure and inside of a tumor is collapsing the blood vessels actually is relevant to not only chemotherapy and radiation, but also to immunotherapy, because we've got to get those lymphocytes into the tumor to do their work. The problem is that tumors have learned how to evade or suppress the immune system. The environment inside tumors can be very dangerous for immune cells. So that's why being able to change the environment of a tumor from the outside without having to open up a patient or to do surgeries or to use drugs for that matter, which may or may not combine well with immunotherapy, is very attractive to me. And I see a great potential for HIFU in modulating the interior of tumors to make the immune system work better.
Some participants came together for a fascinating brainstorming session about the future of ultrasound therapy and about the barriers to its introduction, which must now be demolished.
When I saw the fountain effect and how ultrasound could particleize tissue and tumors. I'm an immunologist, and the first thing that came to mind is that this could be a very valuable way of making antigens accessible to dendritic cells and macrophages, which is one of the barriers to more successful immunotherapy, is that it's hard for the immune cells to sometimes penetrate tumors. And techniques like this, which are non-invasive, can make tumor antigens more available to the immune system. So for me, the past comes very quickly into the future, and in fact, Gail and I are actually working together trying to test that idea.
Compared to all the other therapeutic mechanisms or modalities that exist, ultrasound is the one thing that can cause that type of mechanical disruption, especially with this the evolution of histotripsy.
Right.
I think that this is incredibly promising, and it's something that no other technology is capable of doing. So I think that this really is the future of therapeutic ultrasound.
It's not only mechanical disruption, is it? It's also the
thermal effects.
Well, no, I'm thinking mechanical effects, but changing the permeability of blood vessels.
Sure.
I mean, you don't have to destroy. You may want to use it as an adjunct to other therapies.
And in fact, it should become the Swiss Army knife of the physicians, because you can ablate tissue, so you can increase temperature, you can deliver drugs, you can induce mechanical effects. By just switching the parameters and that fine-tuning using continuous sonication, then you increase the temperature, you use pulse sonication, you favor mechanical effects, you can play with the amplitude, the frequency, pulse repetition, and you have all those effects on tissue, different effects that you can apply at best for one given pathology.
I like the Swiss Army knife
good
analogy very much.
I think that's a little challenging in the current scheme of medicine, though, because doctors and the way that the NHS runs, the way that most hospital systems runs, is that you specialise. And as a consequence, that means that HIFU is basically only accessible really to the radiologists, because they're the clinicians that know all of the different anatomy. And that makes it a bit tricky to kind of put it into clinical practice, because they are the receiving clinicians. They are not the clinicians that go out and find the patients. So it's about trying to also see how can we be more inclusive of other clinicians who maybe are very specialized.
Yeah, and I think that'll be dependent on ultrasound image guidance, right? So MR image guidance, I don't think that that's possible. I think that with MR image guidance, it's going to be in the purview of either the radiologist or the radiation oncologist. We have a very effective treatment for uterine fibroids, but it's not being adopted by the gynecologist because they aren't in control. The more that we can shift that to patients who are directly caring for these patients, the more rapid the adoption will likely be. In the US, we get all of the specialists together and we discuss cases together. This has improved the communications and the comfort level. So now it's easier to refer someone to a radiologist because they participate directly with patient care. And I think that that's how it's going to make its way in the US is this.
It's the same in the UK. We have MDTs, don't we?
Yeah, and
multidisciplinary.
And that's the kind of thing that I work with a lot. I mean, they already exist, for instance, with fibroids. Gynecologists sit at a table with a radiologist and they discuss, because radiologists already are doing treatments for fibroids. And I think actually that comes to probably my main interest of how we can improve training for the clinicians, because there is, they're not that aware, and we do need to promote the knowledge about HIFU, but it's also how do I actually do this, because there's all these amazing different avenues that people are going down, but I don't see that much energy going into the training and how we train clinicians so that hospital boards can be happy enough that you are safe to use that technology. And that's really what it comes down to, is are the managers of the hospital going to be happy that these clinicians can give this treatment safely, and are the clinicians going to feel comfortable enough that they're saying, yep, I'm signing my name on the dotted line, you can fire that shot into the body.
That's where they're good in China. They have specifically trained HIFU doctors. A HIFU DIFU.
There's just a few more steps that are needed, really, in terms of imaging guidance and monitoring. If we can just figure those few steps out, this will be a highly accessible technology that will replace many surgeries. It'll replace a lot of operations. It'll be cost effective. It's what every government wants. This is one of these rare technologies that will save health systems money.
What was very interesting with the work I'm doing, trying to set up just a fibroid service, is that we hadn't even set up the service, but we were getting referrals. And it's because there's been a lot of patient groups for fibroids, and they've actually done their research, they knew about HIFU, and they were prompting the clinicians to say, hey, we really want this technology. So sometimes it actually isn't the clinicians that drive it, it's the patients who start finding out about it. So maybe our role is actually to let them know, so that they can lobby to say, actually, we want this, we want non-invasive treatments, we don't want to have our uterus taken out for this pathology, we want to have a chance of getting pregnant.
Patient groups are very powerful, certainly in the UK, I don't know about in the United States, and we really do need to be informing patient groups.
Yeah.
If we apply for funding now, we almost always have to involve relevant patient groups. That's good, that's a step forward.
If one can detect cancer at a very early stage, it means that we would have to treat a couple of cubic millimeters. And in that case, highly focused ultrasound, you just come and you sonicate just once, 20 seconds, and you're done. And so the targeting would be great, and diagnostic would be done so quickly. So that there would be avenues for this technology, non-invasive, and you treat as soon as you detect.
I gave this presentation for these people, and everybody thought it was a good idea. I said, in the future, you're going to walk into this place, and you're going to have water filled up to about right here. There's going to be a whole bunch of transducers around, imaging your whole body. And then somebody was sitting at a monitor and they say, hey, there's a little spot there, it's cancer. Push this button, boom, it's gone. 3-body therapy, 3-body imaging. And everybody laughed, but we might be there.
Yeah. We do that already in medicine. Okay, it's that's what colonoscopies are. We go in there, we have an early detection scheme. They're all, none of them are cancer, they're all polyps, they're all precancerous lesions. What do? We take them out.
Same with cervix.
Yeah, so I mean, there's already that model. The key is the intervention has to be safe.
Someone explained very simply to me that they said, this is the future. You'll take a tablet and it'll be a liposome, so in a fat-filled sac, and it'll have the drug inside, and it goes through your body and it'll have a tracker, then you get your iPhone and you have your cancer, and when you see it running over the cancer, you get your iPhone, you scan it with your HIFU, and you've just treated yourself. And that's like, that's the really cool sci-fi that you go, yeah, that's the HIFU I would love.
The difficulty today is that clinicians are not believing in this, and they want something easy. And as a surgeon or interventional oncologist, we want to work with our hands too. You see, we have been trained to use our skills, and HIFU is just intellectual. You have to program the same thing you are doing manually or with devices with the HIFU. It means for many, many young clinicians who love to use what they have learned, it's becoming, sometimes they think is too long, boring, perhaps that's not their job, but this is their job, because when you're able to treat tumors, you have the understanding of treatment of cancer or pain. You are the person who needs to learn about HIFU. You are the best person who can apply this technology because you have the knowledge.
The fact that we can make the blood-brain barrier more permeable to drugs is really exciting. The fact that we can use ultrasound to get more of existing Alzheimer's drugs out of the blood vessels into the brain is really exciting. So maybe that will be a treatment for Alzheimer's in the future. Ultrasound is also being used to treat depression and obsessive-compulsive disease. These are things that we know very little about, but maybe in the future that's where we'll be seeing a lot of therapy ultrasound. The brain is a very exciting organ for therapy ultrasound, and it's one that we never thought of in the past, but I think in the future we're going to see a lot more of it.
This is just lovely. You are so lucky to do this job. It's not a routine. Every day is different.
Yeah, constantly being challenged by our students.
Yes, we are very lucky. And it's a passion of innovation, passion of treating patients with new technology, and this is something we need to contaminate our students with it. The passion, loving to do what we do, and do research and clinical work at the same time.
And it doesn't hurt to be in Les Ouches.
Yes.
My research is looking at how small nuclei, small bubbles, can essentially cavitate. They can get bigger and smaller inside of a tumor, and that permits little local changes in the permeability of the tissue such that drugs, really large, big drugs, can get pumped into tumors. And we haven't been able to do that, and clinically this is a big issue. Now we have next generation drugs, and often these are large monoclonal antibody species, and their physical size limits how far they can penetrate into a tumor. So if we're able to manipulate that externally by using ultrasound plus some sort of a cavitation nuclei, we're able to really change treatment outcomes. And this could be really exciting.